Okay, now let's talk about squamous cell carcinoma or epithelioma. It is a 4-marker question in surgery, so let's see what are things we have to write for a 4-marker question. Coming to the definition part, it occurs in pre-malignant conditions. Squamous cell carcinoma is occurring in pre-malignant conditions like Bowen's disease, Paget's disease, leukoplakia, chronic scar, etc. It is arising from the squamous layer of the skin. It is squamous cell carcinoma, so it should arise from squamous layer of the skin. Usually it is occurring in the pre-existing predisposing lesion. That's I have already told you in the prior like pre-malignant conditions like Bowen's, Paget. So usually it occurs in pre-existing predisposing lesions, but occasionally it can develop from the de novo skin also. So it is occurs in pre-malignant conditions. What are those pre-malignant conditions? Bowen's disease, Paget's disease, leukoplakia, chronic scar, etc. It arises from the squamous layer of the skin. Usually it occurs in a pre-existing predisposing lesion, but occasionally it can develop from the de novo skin also. And it is the second most common skin cancer, and it is common in males. Coming to the etiology, that's etiology we have already discussed prior, but still I am telling Bowen's disease or other pre-malignant conditions, exposure to the UVB rays, chronic scars or sinuses, lupus vulgaris, solar keratosis, xeroderma pigmentosa, tobacco use, and coming to the viral cause, human papilloma virus, strains are 5, 16 and 18. If you want, you can remember the strain. And any chemically induced chronic irritation, radiodermatitis. Etiology I'll repeat once again. Please try to remember some 4 to 5 points from this. Bowen's or Paget's disease, leukoplakia, those you can discuss from the previous slide. Along with that, exposure to the UV beta rays, chronic scars or sinuses, lupus vulgaris, solar keratosis, xeroderma pigmentosa, tobacco use. Coming to the virus, HPV, the strains are 5, 16 and 18. Chemically induced chronic irritation, radiodermatitis. Coming to the common sites. What are the common sites we will be having the squamous cell carcinoma? Most commonly dorsum of the hand, limbs, face, skin of the abdominal wall, external genitalia, mucocutaneous junction, oral cavity, respiratory system, etc. etc. There are so many places. You can remember the first initial ones like dorsum of the hand, limb, face, skin of the abdomen, and external genitalia. That's it. Coming to the features. These squamous cell carcinomas are ulcerative or ulceroproliferative or proliferative lesion. They are ulcerative, ulceroproliferative or proliferative lesion. Raised and everted edge, infuriated base and edge, bloody discharge from the lesion. These you have to write as features, the characteristic features for the squamous cell carcinoma. These squamous cell carcinomas can be ulcerative, it can be ulceroproliferative, or it can be proliferative. The squamous cell carcinomas will be having raised and everted edge, infuriated base and edge, bloody discharge from the lesion. So 2 points I have studied. There can be 3 types of lesions: ulcerative, ulceroproliferative and proliferative, and raised and everted edge, infuriated base and edge, bloody discharge. Regional lymph nodes are commonly involved, which are hard, nodular, initially mobile, but eventually it will be fixed to the underlying structures. So first 2 points was about the features, and third one is about the regional lymph nodes. It is commonly involved. First it will be hard, nodular and initially mobile, and then it will be fixed to the underlying structures. Usually blood spread does not occur. So 5% only it can occur, and 5% is occurring when there are some risk factors. What are those risk factors? Immunosuppression, that growth is very large, perineural and deep infiltrative, purely differentiated. In those cases only metastatic will be developing. Otherwise, usually blood spread does not occur in squamous cell carcinoma. So these are the features that you have to keep in mind. Now let's see the histology points. In histology, we'll be seeing malignant whorls of squamous cells with epithelial or keratin whorls. This is the characteristic histologic feature of squamous cell carcinoma. Malignant whorls of squamous cells with epithelial or keratin whorls. This you have to write. You have to keep in mind. Malignant whorls of squamous cells. Malignant whorls of squamous cells with epithelial or keratin whorls. Spindle cells will be there. Invasion and deep peripheral margin clearance. And coming to the high risk factors. What are the high risk features? If the depth is greater than 2 mm and if the histologically it is poorly differentiated, there is perineural invasion, then these are the high risk features. Coming to the tumor markers, cytokeratin 1 and 10 will be positive. Epithelial membrane antigen EMA-MUC1 will be positive. So histologically, the first point is very important that you have to keep in mind. Malignant whorls of squamous cells with epithelial or keratin pearls. Malignant whorls of squamous cells with epithelial or keratin pearls. Spindle cells, invasion, deep and peripheral margin clearance. High-risk features are if the depth is more than 2 mm, it is poorly differentiated and there is perineural invasion. Coming to the tumor marker, cytokeratin 1 and 10 will be positive and also epithelial membrane antigen EMA, epithelial membrane antigen EMA-MUC1 will be positive. These are the histological features. Coming to one more classification is there for squamous cell carcinoma, that is Broder's classification. There are 1, 2, 3 and 4. The first stage is well differentiated and 75% or more keratin pearls are there. The second stage is moderately differentiated. Third is poorly differentiated and fourth is undifferentiated or anaplastic. So 1, 2, 3, 4, there are 4 stages. One is well differentiated, second one is moderately differentiated, third is poorly differentiated and fourth is undifferentiated or anaplastic. And coming to the keratin pearls percentage, first is 75 and then you can remember it as 50 to 75, 25 to 50 and then less than 25. So you can remember it is easy. The name is Broder's classification. Very important. Coming to differential diagnosis, you can write basal cell carcinoma, melanoma, keratoaconthoma, skin adnexal tumors, actinic keratosis, pyogenic granuloma. This you can just keep in mind, some 1 or 2 names, that's it. Basal cell carcinoma, melanoma, keratoaconthoma, etc. Coming to the investigation, there are mainly 4. Wedge biopsy from the edge. One is wedge biopsy from the edge, fine needle aspiration cytology, FNAC from lymph nodes. Wedge biopsy from the edge, FNAC from the lymph nodes, CT scan to identify the nodal disease and MRI to identify the local extension. So these are the investigations that we are doing to this patient. Only 4 that I think you guys know now. Wedge biopsy from the edge, FNAC from lymph nodes, CT scan to identify nodal disease, MRI to identify the local extension. Coming to the treatment part, radiotherapy using radiation needles and bounds are given, and wide excision 2 cm clearance followed by skin grafting of flaps. Radiotherapy is given, wide excision 2 cm clearance following by the skin grafting. MOHS procedure. What is MOHS? It is one of the procedure that is doing it for the skin cancers. So MOHS is one scientist name and also micrographically oriented histographic surgery it is. So that is not widely used but that is there as a treatment modality. The next one is amputation with one joint above. So treatments modalities as of now are radiotherapy, wide excision, 2 cm clearance followed by skin grafting. MOHS procedure, MOHS procedure, micrographically oriented histographic surgery, micrographically oriented histographic surgery. Amputation with one joint above. And for the lymph nodes, if the lymph nodes are involved, we can do the block dissection of the regional lymph nodes. So lymph nodes involved, we should do the block dissection of the regional lymph nodes. Radiotherapy, as I have told prior, there are 2 types of radiotherapy. One is curative radiotherapy and one is palliative external radiotherapy. Curative means we have to cure the disease. Curative radiotherapy is useful only in tumors which are not adherent to the deeper plane or deeper cartilages. Because squamous cell carcinoma is radiosensitive, so we can cure the cancer with radiotherapy. Curative radiotherapy and we can use if it is not adherent to the deeper structures. In advanced cases, that is the squamous cell carcinoma that is adhering to the deeper planes or cartilages, we can do external radiotherapy, palliative external radiotherapy to palliate pain, fungation or bleeding, etc. But it is not a curative therapy. So 2 types of radiotherapy are there, palliative and curative, that you can keep in mind. The next one is chemotherapy. Radiotherapy we have discussed, even chemotherapy we can give. What are the drugs that are used for chemotherapy? Methotrexate, vincristine, bleomycin, cisplatin, carboplatin. Methotrexate, vincristine, bleomycin, cisplatin, carboplatin. And field therapy using cryogenic probe or topical fluorouracil or electrodesiccation. Just you can keep in mind these names. Field therapy using cryogenic probe, topical fluorouracil or electrodesiccation. So that's it. It's all about our squamous cell carcinoma. So it can be asked as a 4 marker question. I have taken my points from SRB, so you can go through it and you can just see. 4 marker question, I think this is more than enough to write for a 4 marker. You can just write it in a proper way, approachable, nice way. You can write it as definition part. You have to write, talk about something about etiology, common sites you can mention, features you can mention, and then you can mention about the histological characteristic features. Then you can mention about the different one classification is there, that is broadest classification you can mention, and then you can talk about differential diagnosis if you want, and then investigation and management. So that's it, guys. See you again with another module.